Dear Antonio, ladies and gentlemen, my name is Andreas Imhoff from Munich. I'm the chairman of the Orthopedic Sports Medicine department at the University in Munich. It's an honor for me to speak at your annual congress of the Asociación Mexicana de Cirugía Reconstructiva Articular. I will speak about the three-dimensional regular alignment and slope-reducing osteotomy with anatomic ACL reconstruction in patients with revision ACL deficiency. Here are my royalties. What is the rationale for osteotomy in chronic knee instability? We want to unload the unicompartmental osteoarthritis, we want to protect the graft, and we want to stabilize the joint. This is the rationale. And why it's important? Because we see an increasing sports participation in middle-aged patients. We see more knee ligament injuries. The need for cruciate ligament reconstruction is higher, and we still have a clinical problem, the osteoarthritis. Shall we treat only the ACL reconstruction with HTO or nothing? We know that the impact of osseous malalignment and realignment procedures in knee ligament surgery is quite big. In the frontal plane and in the sagittal plane, we look close a little bit. It's important to analyze the alignment in the frontal plane, but also in the sagittal plane, mainly the posterior tibial slope. We start with the frontal plane. We have three types of varus malalignment in chronic knee instability: the primary varus, double varus, triple varus. Triple varus means we have an additional lateral opening, and here we have a hyperextension and rotation. The varus alignment leads to increased forces in the anterior cruciate ligament, especially with a thrust, and this can yield to high ACL tensions that can be responsible for failure of ACL reconstruction. Varus and ACL deficiency at the same time. We can do the HTO alone or combined with ACL reconstruction. In this clinical outcome review, systematic review, it was clear that HTO alone was reported to improve the knee instability in some ACL deficient knees, but the combined HTO with ACL revision was superior and could improve the posterior stability much better than HTO alone. That's my approach. I use a carbon plate, peak power HTO plate from Matrix, because now with these angle stable screws we can change the position. We have still enough space for tunnels for our ACL, even if we do a double band reconstruction anterior or medial of the plate, both is possible. The correction of varus alignment should be in two planes biplanar. You see the osteotomy behind the tuberosity. When we open it, as you can see here, because of this plate, we can clearly see the bone and the osteotomy itself. How much should we correct? If we have just a medial overload and ACL instability, we do an HTO to 55%. If we do some cartilage therapy at the same time, also something like that, then we go to 60%. If we have a posterolateral or lateral opening together with a bigger combined cartilage therapy at the same time, we go to 65% to unload the compartment. What about the sagittal plane? As you can see here, we have this sagittal this tibial slope, and we know that the role of tibial slope has a big impact on the biomechanics. The quadriceps muscle forces go like here, and the tibia femoral compression load goes like this, so the tibia will shift anterior, and we will have much more tension in the ACL itself. We have a five-fold increased risk for further ACL injury in patients with a higher slope in this prospective 15-year follow-up of 200 ACL reconstruction. My son Florian did a nice study. Slope-reducing tibial osteotomy decreases the ACL graft forces and anterior tibial translation under axial load at the same time. That's why we should think about the slope-reducing osteotomy to protect the ACL in revision cases, especially. It seems that it really can protect. It's just published in KSTA. So how much should we correct? The slope is around 10 degrees. That's just a consensus. 10 degrees. So when you modify the slope think about planning the osteotomy about 10 degrees, and we measure the middle line. We use the middle line of the tibia for measuring the slope. When we do the osteotomy, we go from the front, we lift the tuberosity, we have several key wires here, and then it's easy to take out this anterior wedge and close the wedge using this blade and 2 additional screws for the tuberosity, and you have a nice reconstruction of the tibia. That's why we always use 2 key wires in front in the sagittal plane to see how much we change the slope, and also to understand the rotation of the distal part of the tibia, because with osteotomy you always have a slight internal rotation because of the hamstring tendon, and we do not want that when you do an osteotomy. Just a case, 46-year-old male after ACL reconstruction, now failure, symptomatic instability. This is the planning. You see opening wedge on the medial side, and now that's what we can do. When you reduce the slope at the same time 5 degrees, like here, you can open posterior, you can with the biplanar, you still have contact to the bone and you still get a nice healing. This is the case here. You see the osteotomy and the tuberosity was shifted and fixed again. Now we have 0 degree at the end, 5 degree in the beginning when we measure the posterior edge here. But think about the tibia femoral rotation is also important. When you change the slope, medial and lateral is not the same. Our experience with 44 patients with a new instability after ACL reconstruction, 4.5 degree was the varus, the mean slope was 14 degree, mean age was 38 years, mean follow-up was 45 months, and these are the results. The postoperative valgus angle was 1.5, slope was 8 degree, and we could increase the pain score, the Lysholm score, the IKDC score, and the thickness scale at the same time. So in summary, think about frontal and sagittal malalignment are relevant in chronic ACL deficient patients. If we have a varus malalignment, especially a varus thrust with failed ACL reconstruction, consider valgus HTO. In ACL deficiency and reconstruction, a flat tibial slope is associated with less anterior tibial translation, lower risk of ACL graft failure, and lower ACL graft forces. So consider slope reducing HTO at the same time. And our results now give us a good background that we can combine everything, 3-dimensional alignment, varus, rotation, HTO, and revision ACL at the same time. So that's what we recommend today. So thank you very much for your attention, and I'm happy to answer all questions. Maybe after you can send me an email, because it's just some time delay between Germany and Mexico. Thank you very much.